Interventions with a King. Discussion and commentary based on articles from JACC, Cardiovascular Interventions.
Hi, Dr. David Moliterno. I'm one of the associate editors for JACC Cardiovascular Intervention. I'm Chief of Cardiovascular Medicine at the University of Kentucky, and I'm joined today by two colleagues. On my immediate left is Dr. Robert van Grens from Rotterdam, the Netherlands. And on the far side, Dr. Michael Kutcher, who's at Wake Forest University. And today we've got a very interesting paper in press that we'd like to present to you, and we'll start out talking with Dr. van Grens about this paper, which deals with a subject important to interventional cardiologists. It has to do with the completeness of myocardial revascularization and then trying to understand, is the myocardium going to recover? So somebody with multivessel disease, and we can see some asynergy or dyssynergy, some lack of contractility, and then trying to understand, are we going to get benefit from the revascularization procedure? So I'm going to turn to Dr. van Grens and have us just talk a little bit about the study and what he found.
Yeah, thank you, David, for the introduction. We studied patients. We were selected for multivessel PCI with known depressed LV function. We were interested if the multivessel PCI was going to improve left ventricular function. So we decided to do MRI pre and post to study the left ventricular function. And we divided the groups in three groups, where we found that the patients who had complete revascularization for their depressed LV function had an improvement of ejection fraction of 4 percentage points, compared to the patients who had incomplete or unsuccessful attempt for PCI, where there was no change in ejection fraction.
So that's important to know then, that some of the patients were completely revascularized, some partial, and some had no revascularization at all. And these patients were all undergoing PCI, right?
They were all undergoing PCI.
Good. So I'll turn to Dr. Kutcher now and say, does that make sense to you? Patients who are more revascularized are going to have an improvement in their left ventricular function?
Yes, Dave. The task for the interventional cardiologist is not so much can you do something, but is it right to do? Complete revascularization is very important, as Hannon and the New York State Registry showed that incomplete revascularization has a very bad long-term mortality morbidity. So we need to know if our procedure will be complete or if it's going to be incomplete.
One of the challenges, though, that we've been faced with, Robert, in the past is just not knowing if the myocardium is going to wake up, so to speak. If it's hibernating, is it going to come alive? Some in the past have proposed using dobutamine echocardiography or PET scintigraphy. So tell us what drew you to do cardiac MRI, and what are the pitfalls perhaps, and what you found again.
We used MRI because I think it is the most reliable, reproducible technology to study the left ventricular function at baseline and at follow-up, and also the regional function. Also, there has been a lot of studies going on viability assessment with MRI, and we used two parameters in this study because the well-known transmurality extent of the infarction, compare that to the low-dose dobutamine stress to see the improvement in function before. And what we found out that there was indeed a predictive value of the transmurality of infarction, but the low-dose dobutamine was a better predictor for recovery of function after PCI.
So Michael, help me put this in perspective then. How should I apply it to my practice?
Well, I think this Robert's group has added another element of help to the interventionalist, and that is the functional assessment of what we're going to do with revascularization. This is somewhat similar to the FAME study, where now we're being guided by fractional flow reserve. I think viability is a very, very important key assessment for completeness of revascularization, and MRI has the best promise for being more accurate of how to assess this and predict viability.
Okay, very good. So in our final minute here, Robert, tell us, where will you go next? Do you have any other studies in mind or thoughts about what you'll do next?
Yeah, we have two interesting questions to answer. The first is, I think we have to follow the FAME tragedy there. But we know that FFR has been a long time, but they now have a randomized study with all the follow-up of that. So we have to use this MRI viability also in a randomized fashion upfront and use that for the decision making, if that really is influencing our decision making.
Got it. So it makes a lot of sense, and I think we'll see more research along these lines as cardiovascular MRI becomes more widespread throughout the world. a very interesting topic, and I look forward to hearing more about it. Thanks for joining us today.